From the beginning of the planning of this set of workshops, one of the themes that we wish to emphasize was notable successes in low resource settings, particularly those where there was a generalizable message, both domestically and in international settings. And in that context, I'm pleased to welcome as our next speaker, Dr. Doyin Oluwole. She is Chief Executive Officer of the Global Health Innovations and Action Foundation in Dallas, which is an organization established to address global health challenges of our time through commitment to healthcare education, research, and service. A pediatrician by training, Dr. Oluwole has had a distinguished career in designing and implementing disease prevention and health promotion programs in countries of Africa and in other resource-limited settings. Dr. Oluwole.
Good morning. It's an honor to be here this morning and in my new role, but many friends in the room. The work that I'm going to be presenting today represents work that was done by my colleagues and myself at the Pink Ribbon, Red Ribbon. Some of the partners are in the room over the first 3.5 years of the program or the partnership. The beauty of this session is that it has allowed us to see a spectrum of activities in the US, domestic, and I'm happy to bring the African perspective to this session. I hope I can make this work. So I'm going to be presenting to you based on the topic of the session, one best practice in prevention and another best practice in screening, early detection, and treatment using cervical cancer as the example. Before we understand exactly what we're talking about in cancer control and care, I thought, just like the other speakers have done, it's important for us to see the spectrum of the continuum of cancer care, and for us to appreciate the fact that we should not begin screening or early detection without putting in place appropriate strategies for treatment and indeed palliation. So I talk of the continuum of cancer care from prevention right through to palliative care, or from vaccine to morphine and all that is in between. People would say to you, this is too complex, it's too expensive, but we know that at the end of the day, without this continuum of cancer care, we will not make a difference in outcome. So let's look at Botswana as an example of a success story in cervical cancer prevention. Quick update on the demographics. It's a very small country, 2 million population. The female population is about 50%, and women between 30 and 49 years are like a 250,000. Sorry for the repeat there. HIV/AIDS had been devastating that country for decades. Indeed, in the early days, they recorded almost 35 to 40% prevalence of HIV in the community. But we know that that country took the bull by the horn and put their money into HIV prevention as well as treatment. Today, we're talking of a country with approximately 23% prevalence and PMTCT rate of less than 3%. This is how successful Botswana has been. And that is relevant to what I'm going to be talking about today. When you look at 2012 data for Botswana, the two most commonly diagnosed new cancers in the country were cervical and breast cancer. Cervical cancer was almost a third in the population. And you see that breast cancer follows closely. That country does not have a program on breast cancer. But because of the HIV prevalence and the success that they have recorded with HIV prevention and control, they recognized early the need to tackle cervical cancer. So what were the challenges that we encountered in 2012 when we first engaged in Botswana? There were competing priorities. You found that the limited EPI staff were overworked, but they were also laser focused on childhood immunizations. And I recall the permanent secretary saying to me, do not talk to us about HPV vaccination until 2017. He showed me the plan, how he was going to roll out the childhood immunizations, the new immunizations that they were to take on board, and he gave me every reason that would stop us from talking about HPV vaccination. Policy at that time, there was no national injection safety policy, and there was a delay in the rollout of auto-destruct disabled syringe usage in the country. So they were still using the multiple syringe type. Management, stock management was not at its best. It was inadequate, and it was difficult for them actually to forecast the need for vaccines. The data was not readily available, and therefore they could not even say to us if they were going to adopt HPV vaccination, what is the target population and how would they forecast the vaccine needs. Sustainability was also an issue. One of the earlier speakers talked about the cost of HPV vaccine. Botswana is not Gavi eligible, and so they cannot buy vaccine at $4.50 that low-income countries are getting it from Gavi. They have to pay something comparable to what the Central American countries are paying, which is about $13 at least per dose. And the permanent secretary was, so doctor, how do you want me to finance this? And even if I did, how do I sustain it? So we had these realistic challenges ahead of us. But we also had great opportunities, which we capitalized upon to enable us make the inroad. The first is the fact that the Ministry of Health definitely provided leadership. They were well respected in the community. They had good oversight over the health programs in the country, and we thought the advocacy efforts that they had put in place were such that we could ride upon if we were able to make an agreement with them. Government was committed and remains committed even today. They allocate their own resources for training health workers for new vaccines. And therefore, we felt this is another new vaccine, HPV vaccine. Therefore, since health workers were already being trained on new vaccines, we could incorporate this training into the already existing ones and use the same resources to make this happen. And we also capitalized on the fact that based on our knowledge of Botswana, once they were convinced that something was good for the country and they adopted it, they will follow through. But they needed to be convinced that it was good for the population. Because they have a high school enrollment, including girls, over 95% are enrolled in primary school. It was a good opportunity also for us to catch the 9 to 13-year-olds in a school-based program. And therefore, these were some of the arguments that we presented to the permanent secretary. The high HIV prevalence, you could look at as a big challenge, but we capitalized on that and used this as an opportunity to actually convince the permanent secretary that the young girls that have been kept alive through access to antiretrovirals, this was the big opportunity for him to prevent them in later years from developing cervical cancer and spending 10 times or more treating cervical cancer. Somehow, that was the breaking point. It made sense to him. He looked at the age group of girls and he said, that is true. 10 years down the line, this would be the girls that would be presenting with cervical cancer. But there was still the issue of funding. And public-private partnerships answered that question. Because, as you all know, Pink Ribbon, Red Ribbon has the 2 vaccine manufacturers in the partnership. And we were able to get one of the vaccine manufacturers to agree to donate a number of doses of HPV vaccine for the country to do a demonstration and see whether this is really something that they could adopt. And you will see more of that later. So what we did with the public-private partnership in Pink Ribbon, Red Ribbon was to look at all of the partners that could contribute to this work. But we did not stop at just the prevention. We looked at partners that could help us with the continuum of cancer care, which I talked about earlier on. Some of them are in the room here, the US government. I won't go through the whole list, but you can see them all listed. And we brought people together with the national government itself committed to achieving something in the country. We got Merck to donate vaccine doses, 7,800 vaccine doses, Gardasil. And the government agreed, okay, we'll try it in 1 district. If it does not work, we give it up. If it does work, within the 2nd year, we would make sure that we incorporated this into our national budget. And so they went through a school-based HPV vaccination program, but they did not leave it at that. Knowing that they had approximately 2 to 5% that were not enrolled in schools, they also made available vaccines in some of the facilities to cover the non-school going 9 to 13-year-olds. And here you see the Minister of Health herself visiting the sites where the program was being carried out. What was the outcome? We got tangible results. First, the country developed a national policy on cervical cancer. It was a comprehensive one that covered from prevention right through to palliative care and included HPV vaccination. We had a catalyst for action. As I mentioned earlier on, Merck donated the vaccines. Other resources came on board for training. We were able to get $1 million from the World Bank to support the process out of the HIV program that was already in country. It was a reprogramming. And the argument was, if we did this, it would enable us to do more for HIV positive population. And that resonated with the bank, and they came on board with us. In that first demonstration, 2,015 girls were fully vaccinated with 3 doses of HPV vaccine. And this represented over 95% of the target population. It was, of course, preceded by a lot of advocacy, awareness raising, with members of the parliament going out to the constituencies and informing the people. Did we have any challenges during the process? Of course we did. Social media came in, and just one person went on social media and said they were sterilizing the girls. Because it was only girls targeted, the boys were not included, and it took the parliamentarians to go back to their constituencies and debunk this myth. We facilitated the connection between Botswana and PATH, and we got a consultant to help with the post-introduction evaluation. The good thing was government was very much involved in this post-introduction evaluation, and at the end of it, they adopted the consultant's recommendation for a second year of demonstration, just to test the systems again before doing a nationwide rollout. At the end of that first year demonstration, I recall this statement that I have included here from the permanent secretary. We cannot go back. Communities are demanding services. Because this was only in Molopolole district, all the other districts kept asking, why are we not included? And the voice of the people is always very important. So what happened? In that first year, 2015 girls. In the second year, over 6,000 girls were vaccinated, again 3 doses. And the good news about Botswana is that following that second year, government indeed incorporated HPV vaccination into their budget, and from 2015, they took over the procurement, the process, the management, and monitoring and evaluation of a nationwide rollout of HPV vaccination. In 2015, the first dose of a 2-dose strategy that they adopted was delivered to a target population of 69,000 girls. Remember, from 2,000 to 6,000 and now 69,000. First dose, they covered 68,304 girls. The second dose, I have no doubt in my mind that it will be at least 68,000. That was done in September this year. All owned, led, funded, monitored by the government itself. When you talk about sustainability, when you talk about government commitment, when you talk of ownership, this is an example of a national government owning its own program and putting its money where its mouth is. I have included there number of women screened so that you would see that we were not stopping at HPV vaccination. We actually incorporated the screening and treatment, and I will show you in the next slide how this is going on. So again, government fully owns the process, and HPV vaccination is now fully embedded in the national EPI program, and there is a dedicated national program manager. It is also incorporated into the national budget so that they are buying their own needles, syringes, paying their staff, and managing the implementation themselves. And our friends from National Cancer Institute, just before I left, started helping us to evaluate the first 5 years of this program in Botswana. I'm sure there will be lots of findings, lessons learned to inform the next 5 years of the program. So quickly, let me give you a second example of Zambia for early detection and treatment. These are the demographics. As opposed to Botswana, this is 13 million people, female population, again about 50%. But you see the age group 30 to 49, 1.1 or 1.2 million women. HIV prevalence also pretty high, and 490,000 women living over age 15 living with HIV. Similar to Botswana, cervical and breast cancer, but you see the prevalence of cervical cancer in Botswana, 36.7%. It's the second highest prevalence globally and highest mortality globally, and is the most common cancer in women. And unfortunately, 40% of the women who present with late-stage cancer are less than 35 years. So it's younger age group. So what would you say were the challenges to combating cervical cancer in Zambia? Basically, access. Lack of access to information, lots of myths. Cancer is not preventable. There is nothing I can do about it. You know, anybody who gets cancer is a death sentence, and everybody who goes to hospital dies, whereas the reason they die is the late presentation. And it is due to evil spirits. We should not associate with women who have cancer, etc., etc. And therefore, it's shrouded in secrecy, in silence. And a lot of women will keep these things to themselves and not come out for treatment at the stage where they could be helped. And of course, geographic access is a big issue in Zambia. 13 million population, only one cancer treatment center, and it is in Lusaka. What were the other challenges? When we got in there, they were focused on maternal and child health and HIV, because those were the recognized causes of morbidity and mortality. No national strategy and therefore no roadmap. Their work was mainly driven by an NGO. And at that time, they had two ministries. The Ministry of Health had been split into two. Ministry of Health, Ministry of Community Development, Mother and Child Health, and they were still in the process of determining who would do what. Sustainability, because it's a poor country, no national cervical cancer control program, and the funding to be able to do the work was considered impossible. And as I mentioned earlier, only one cancer treatment center. As of last year, this was the kind of challenge in terms of access. This is the National Health Promotion Manager traveling out with her team to an area in Western Province and the kind of access issues that they had to reach the women. But we also had opportunities. At that time, the First Lady, the Minister of Health, the Permanent Secretary were all OBGYNs who knew the implication of cervical cancer and what needed to be done. The US ambassador was very supportive, and there is a very strong PEPFAR platform on ground. VIA, cryotherapy, LEAP, and even cancer care were declared free by government, but free for those who could access. Technical capacity was available at the Center for Infectious Disease Research of Zambia, at the Cancer Diseases Hospital. Indeed, that hospital is probably one of the best in sub-Saharan Africa. And you had CDC that was extremely supportive as well. Committed NGOs like PCI and others. And also we had the opportunity to leverage the HIV platforms in place. And of course, public-private partnerships. So again, we harnessed all the resources that were available to us from all these NGOs, and see the list of them. Again, I will not go through, but these were all the partners that came together and said we would support Zambia in this process. And so Zambia adopted or decided to scale up its single visit approach of VIA and cryotherapy LEAP. Equipment were purchased, health workers were trained. Indeed, some of the partners helped to refurbish clinics and open them up for women to access the services. And what were the results? Again, you can see here, between 2012 and 2014, 155,000 women were screened, out of which 11,719 were actually treated with with cryotherapy or LEAP. And we also instituted HPV vaccination. And by that time, by the end of 2014, almost 34,000 girls were vaccinated. What were the lessons that we've learned from these two countries, looking at the prevention as well as early detection and treatment? The first and most important is that local grassroots efforts are critical to a successful program, or indeed to getting governments to adopt a program. In Botswana, as I mentioned, because other districts were asking or demanding services, government could no longer pull back, and they had to reprogram resources, ask for additional resources to be able to continue the HPV vaccination. Presence of NGOs, in particular in Zambia. We had PCI that was helping to do outreach activities, mobile services, and together with the Ministry of Health, and sometimes with the presence of the First Lady herself, helping to lead the effort and actually working to screen and treat women. People also came out. So it's important to include all of these people. Government needs to own the process, and sustainability depends very much upon how government owns, leads, and fully commits to delivering this program and scaling it up. So what are the strategies that I would recommend for replication? I think in most of African countries, the problem is access. And therefore, any step that would help to improve access to education, to information, to vaccination, to services, from training of health workers, equipping the health workers, making sure that the services are not just limited to fixed facilities, but that outreach activities are included. And of course, as we look to the future, looking at the possibility of point-of-care testing and screening in an integrated approach that would allow women to be reached wherever they are and will provide not just cervical cancer screening, but also other services that women require as they go out there to seek care, so that that single day that they have devoted to health care for their family can be maximized. They do not have to lose days off market, off household chores, or their livelihood. And access to treatment. This is critical. Many of the countries have substandard cancer treatment centers. Thanks to some of our partners present here, NCI, MD Anderson, they were helping us, and I'm sure they're still helping, to develop capacity for cancer care, for cancer registry. This is extremely important. So access to all of this would definitely improve outcomes, not just for cervical cancer, but for cancer at large. In conclusion, despite the huge challenges that you have seen and heard in combating cancer in low-resource centers, I am convinced from the 3.5 years of work that we did in Pink Ribbon, Red Ribbon, that the health system issues can be overcome if we would apply proven, simple, cost-effective interventions, and we would be giving hope to families so that they know that cancer diagnosis is not a death sentence, but that also cancer can be prevented. But in order to make sure that this is sustainable, government leadership and ownership is absolutely critical. Thank you so much for your attention.